Good afternoon, guys. Discussion B deals with witnessing cognitive decline, and it's from an article that came up on my screen from agingcare.com. Okay, it's a site where people can ask elderly questions and such, and sometimes I get show ideas from them. Okay, so now today I've gotten an article, Dementia Witnessing Cognitive Decline on agingcare.com, offers a deeply personal and poignant account of one caregiver's experience watching her loved one, Charlie, gradually lose cognitive abilities due to stroke induced dementia. Core themes of the texts: sudden onset and subtle signs. The narrative begins with Charlie experiencing confusion during a routine ATV ride, which marked the first noticeable symptom of, of a mild stroke. A retrospective reflection reveals that earlier, smaller strokes had gone unnoticed, highlighting how early dementia symptoms can be masked by misinterpreted the caregiver describes Charlie's transformation from a capable, independent man to someone increasingly dependent. His his spatial awareness, memory, and ability to perform everyday tasks deteriorated. He forgets familiar locations like the washer, and becomes disoriented even in grocery store. Emotional toll and safety concerns. The caregiver expresses growing anxiety about leaving Charlie alone, fearing he won't remember to use emergency systems like med alerts. His panic, his panic when she's away, and an inability to recall recent events or family members adds emotional strain and urgency to the caregiving situation. Recognition and identity. Although Charlie still recognizes faces, he struggles with names and relationships. Conversations with close relatives feel foreign to him, underscoring the isolating nature of cognitive decline. Coping and acceptance. The author concludes with a somber reflection. It's sad and frustrating to watch. The brain turn to Swiss cheese. Yet she emphasizes the importance of adapting and coping, even as dementia reshapes the dynamics of care and connection. Broader context from the page. The, the surrounding page includes related articles on Alzheimer's dementia, fixation, and caregiving strategies. A forum for caregivers to ask questions and share experiences. Resources for finding in-home care and assisted living option. The newsletter and care referral service aimed at supporting families navigating elder care. Why this matters. The frustrated account not only illustrates the clinical progression of dementia, but it also humanizes the caregiving journey. So it's a powerful reminder of the emotional, logistical, and ethical complexities involved in supporting someone through cognitive decline. Would you like to explore frameworks for early detection or strategies for caregiver resilience in similar scenarios? Early cognitive decline can manifest in subtle but impactful ways. Recognizing these signs is crucial for timely intervention and support. Here are some of the most common symptoms drawn from both clinical sources and caregiver experiences. Common symptoms of early cognitive decline. Symptom category description. Memory loss, memory loss, frequent forgetfulness, especially of recent events, conversations, or appointments. Language difficulties, trouble finding the right words, frequent pauses in speech or mixing up names, disorientation, getting lost in familiar places, confusion about time and location, executive dysfunction, difficulty planning or organizing or solving problems, e.g., managing finances or following instructions, mood and personality changes, increased irritability, anxiety, depression, or noticeable shifts in personality, apathy and withdrawal, loss of interest in hobbies, social activities, or spending time with loved ones, task completion issues, trouble completing familiar tasks or routines such as cooking or using household appliances. Spatial awareness decline, misjudging distance, bumping into objects, or forgetting the layout of familiar environments. These symptoms often emerge gradually and may be mistaken for normal aging. However, when they begin to interfere with daily life or relationships, they warrant medical evaluation. Would you like to explore screening tools or caregiver strategies tailored to early stage cognitive decline? There are several validated and widely used screening tools detecting early cognitive decline. These tools vary in complexity. Administration, time and culture, adaptability, making them suitable for different care settings and populations. Commonly used cognitive screenings, tool name, description, and strengths. Minicog combines 3-word recall. The test with a clock drawing task, quick 3 minutes, easy to administer, minimal language bias. Montreal Cognitive Assessment, or MoCA, assesses multiple domains, including memory, attention, language, and executive function. Sensitive to mild cognitive impairment, widely used in clinical settings. Mini mental state examination evaluates orientation, memory, attention, and language. Long-standing tool useful for tracking progression over time. General Practitioner Assessment of Cognition, or GPCOG, includes patient and informant components to assess memory and function, validated for primary care, available in multiple languages. Memory impairment screen, or MS, focuses on word recall and recognition, brief and excessive or effective for early memory issues. AD8, Informat interview 8-item questionnaire completed by caregiver or close relative, useful when patient self-report is unreliable. Short IQ COD, Informat-based tool, assessing changes in everyday cognitive function, culturally adaptable, good for longitudinal tracking. NIH Toolbox, comprehensive battery assessing cognition, emotion, and motor, and sensory function. Research grade validated across diverse populations. Choosing the right tool. Selection depends on setting, e.g., primary care versus neurology clinic. Time available. Some tools take 5 minutes. Cultural and language considerations. Need for informed inputs, especially when patient insight is limited. These tools are often used as part of a broader diagnostic process. If a screening test suggests impairment, further neuropsychological evaluation typically recommended. Would you like help designing a screening protocol tailored to frailty aware or memory friendly care environments? Great question. While traditional screening tools are the MMSE and MOCA are widely used, alternative assessment methods offer more nonsense culturally responsive and functionally integrated ways to detect cognitive decline, especially valuable in frailty aware and memory friendly care environments. Alternative assessment methods for cognitive decline. Functional behavioral assessments. Lawson Body ADL scale assesses instrumental activities of daily living, e.g., managing medications, finances, okay, things of that nature. Functional activities questionnaire or facts evaluates real world tasks, performance often more sensitive than memory tests alone. Dementia Severity Rating Scale, or DSRS, tracks changes in daily functioning over time. In format-based tools, IQ, CODE, Informat questionnaire on cognitive decline in the elderly relies on caregiver observation of cognitive changes over time. AD8 dementia screening interview. 8-item tool completed by someone close to the individual useful when self-report is unreliable. Okay. Executive function and decision-making tools. Brief evaluation of executive function, or BEEF, targets planning, inhibition, and cognitive flexibility. Trail making test, or TMT, assesses attention, sequencing, and mental uh, flexibility, often impaired early in neurodegenerative conditions. Self Self assessment and digital tools. BCAT, self assessment, online quizzes for cognition, driving safety and mobility. NeuroQOL measures cognitive concerns alongside emotional and social domains. STAGE, self administered geocognitive exam, paper based tool that can be completed at home and shared with clinicians. Okay, 5. Staging and severity scales. Global Deterioration Scale, or GDS, provides a a 7-stage model of cognitive decline. FAST, functional assessment staging tool, often used in tandem with GDS to pinpoint dementia stage. Why these matter? These methods capture real time, a real world impact of cognitive changes, reduce cultural and educational bias, enable longitudinal tracking, and caregiver input. Okay. Support early intervention in frailty aware care models. Would you like to co-design a hybrid assessment framework that blends cognitive, functional, and environmental insights for underserved or homebound populations? Implementing cognitive assessments in practice, especially in frailty aware or memory friendly environments, requires community and home based settings. Based on the surrounding document, con- content, and best practices, here is a practical framework, practical implementation strategies. Tiered screening protocol. Initial tier. Use brief tools like Minicog or AD8, primary care or community settings. Second tier. If concerns arise, follow up with more detailed assessments like MOCA or trial making tests. Lawton Body ADL. Third tier. Refer for neuropsychological evaluation or geriatric consult if decline is confirmed or complex. caregiver integrated assessment. Incorporate informant based tools, e.g., IQ code, DSRS, during routine visits or telehealth check in. Train caregivers to observe and report changes using structured templates. Environmental and functional contexts. Pair cognitive tools with assessments of home safety, mobility, and social engagement. Use staging tools like FAST or GDS to align cognitive status with care needs and housing adaptations. Digital and self administered options. Deploy tools like Sage or BCATS, self assessment versus patient product, patient portals, or community kiosks. Offer tablet based voice assisted versions for accessibility in low literacy or multilingual populations. Culturally responsive adaptation. Translate tools and adjust scoring norms for diverse populations. Use virtual aids, storytelling formats, or culturally familiar tasks to reduce bias. Longitudinal tracking, embedded assessments into electronic health records for trend analysis, schedule regular intervals every 6 to 12 months assessment, especially in high risk groups. Integration into frailty aware model. Okay, these assessments can be embedded into adult daycare intake protocols, smart housing systems, passive monitoring of task completion. Okay, smart housing systems, passive monitoring of task completion, home health visits with occupational therapists. Okay, guys, we're down to the last page for B, which is community health worker programs targeting underserved seniors. Would you like to co create a sample protocol or toolkit for implementing these assessments in a specific setting like homebound elder care or culturally diverse communities? Okay, guys, so that's B for you. I'll jump back on with C in a little bit. For now, Gator Wellness, take care, folks.